Good morning, one and all. Today's lecture is on behavior management. Behavior management encompasses a huge aspect of pediatric dentistry. Unless and until you're able to manage the behavior of your child patient, you will not be able to treat them well. So it is essential that you know the basics of behavior management and you know how to clinically manage your patients. So basically, to know your children, you need to know the classification of behavior management techniques that we have. We have basically the non-pharmacological, which are psychological and physical behavior modification techniques, which are called the aversive conditioning as well as the pharmacological behavior modification techniques called the conscious sedation, deep sedation, and general anesthesia. So coming to the psychological behavior management techniques, it starts with communication, which can be verbal or non-verbal. Or tender loving care, desensitization, show, voice control, enhancing control, contingency management, distraction modeling, and hypnosis. These are the typical behavior modification techniques, psychological behavior modification techniques that we have in our repertoire to manage children. I will come into each one of this in detail. Basically, communication is divided into verbal and non-verbal. Verbal is when you speak out to the child and listen to the child. That is, you have to have a conversation, which means that you have to tell them the instructions, what is to be expected, make small talk, might as well listen to their concerns and have a two-way conversation. That is why it's called a conversation. You should be a good listener too. You should use a language that the child understands so that you can have a good communication with the child. Your tone should be age representative in the sense like it should be at to the age of the child, where the child would listen to you with interest. Express empathy should be firm, with younger age group should be soothing. Addressing the child, you should always use a nickname or the name of the child so that the child feels that you know the person, you know her or him. Compliment the child when they show good behavior, compliment them on their general attire so that you can develop a rapport with the child. Your message should be short, clear, and in a language that the child understands. So message clarity has to be there, and you can always use euphemisms or word substitutes, which will reduce the fear of the child. Euphemisms are word substitutes which can be used. For example, for a rubber dam, you can say raincoat. For a local anesthetic, you can say sleeping water. Or for the drill, you can say a shower or something like that to reduce the anxiety of the child. You don't use words that increase the anxiety of the child, and speak at eye level. If you're sitting at a very high position, the child might not feel like listening to you. So always speak at eye level. Non-verbal communication is through eye contact, facial expression, and body contact. If the child avoids it, he or she is not fully prepared to cooperate. I'm talking about eye contact. If the child avoids eye contact, he or she is not fully prepared to cooperate. That means you have to still have a behavior modification technique to make the child cooperate, make her look at you so that you can give her or him instructions. Facial expression, you should be smiling. You can raise your eyebrows. You can change your facial expression in different manners as you're listening to the child so that the child feels comfortable talking to you. Body contact is by patting, holding hands, hugging, etc. when they show good behavior. Then coming to systematic desensitization, which was described by Joseph Volpe in 1952. Most useful in children who present with pre-established fears due to previous experiences or negative comments about dentistry. A child who has had previous experience which has modified the child's behavior or has made the child anxious. This behavior modification technique is useful in those children. This technique helps individuals with specific fears or phobias and to overcome them by repeated contacts. So a hierarchy of fear-producing stimuli is constructed and the patient is exposed to them in an ordered manner, starting with the stimulus posing the lowest threat. So initially you make the child go through a very small experience like probably examination, then radiographic evaluation, then prophylaxis or oral hygiene instructions in the first appointment, progressing to more difficult treatments like a restoration or a pulpectomy or an extraction in the coming appointments. So a hierarchy of fear-producing stimuli from the least fear-producing to the most fear-producing is produced so that the child can go through these comfortably. As they become more acute to go through different levels of anxieties, you can progressively expose them to these anxieties and get the treatment done completely and more efficiently. In dental terms, fears are usually related to a specific procedure such as the use of a local anesthetics. So the patient is taught to relax, and if the patient is relaxed, only you will be able to inject very slowly. And in this state of exposed to each of the stimuli in the hierarchy, in turn, only progressing to the next when they feel able to. The child learns to substitute appropriate or adaptive emotional response for an appropriate, inappropriate, or maladaptive response progressively. Third technique is the tell, show, do, which is explained by Edelston in 1959. This encompasses several aspects of social learning theory. It is most effective in children above 3 years, especially during the first visit. A gradation from the least producing, fear producing to the most fear producing should be followed here too. Tell what you are going to do. It is a series of successive approximations. Tell what you are showing. Tell while you are doing. Show what you have told. Show what you will do, and do what you have told and show. This is the sequence that we follow. First, you tell them what you're going to do. When you are showing, also you talk to them. Tell while you're doing, also you're talking to them. Show what you have told. Show what you will do, and do what you have told and show. Voice control is controlled alteration of volume, tone, and pace of the voice to influence and direct the patient's behavior. Sudden and firm commands are effective to get the child's attention. So when the child misbehaves, you can say no, and that no would be in a controlled manner so that the child understands that it is a definite no. So you're not getting angry with the child, you're just altering the volume, tone, and pace of your voice to influence and direct the patient's behavior. Objectives is to gain the patient's attention and compliance and to avoid negative or avoidance behavior, to establish authority as well. It's also called the white noise. Sorry, audio analgesia is called the white noise. Contraindications of voice control. In children who, due to age, disability, medication or emotional immaturity, I'll come into audio analgesia later. Audio analgesia is a technique by which it's called white noise because it's a technique by which you reduce the fear or anxiety of the child. Contraindications of voice control is in children who, due to age, disability, medication or emotional immaturity, are unable to understand and cooperate. Enhancing control. Enhancing control is another behavior modification technique, which is very effective. The patient is given a degree of control over their dentist behavior through a stop signal. This reduces anxiety level because the patient feels that they have some control over the procedure. Such signals have been shown to reduce pain during routine dental treatment and during injection. The stop signal, usually raising an arm, should be rehearsed and the dentist should respond quickly when it is used. So the child is asked to show you a stop sign when he or she feels overwhelmed and not able to go through the procedure. In such a situation, you have to, as soon as the child shows the behavior, you have to stop. This will gain the child's confidence and will be able to, he or she will be able to go through the procedure more comfortably because they know that you are concerned, and if they go through a difficult procedure and if they cannot control their behavior, you will stop the procedure. The technique is useful for all patients who can communicate. Contingency management is done with the use of reinforcers. Positive and negative reinforcers are used to manage the child's behavior. This cartoon of Peanuts says that, this is the child was given a toothbrush after the procedure to reinforce his good behavior while he was looking for a dog or bicycle. So it is not a gift that you're giving. You give a gift which is dentally relevant. Okay? And you will not bribe the child. Bribe and reinforcers are different. Bribe is given or promised before good behavior, whereas a reinforcer is given after the desired behavior is shown. The modification of behavior by the presentation or withdrawal of reinforcers, which can be positive or negative, is called Contingency management. A positive reinforcer is whose contingent presentation increases the frequency of desired behavior. This was given by Henry W. Fields in 1984. So when you continuously present, like every time the child shows a good behavior, you say thank you. That is a positive reinforcement. And the child knows that you are happy by this behavior. Negative reinforcer is what whose contingent withdrawal increases the frequency of desired. This was given by Stokes and Kennedy in 1980. Behavior shaping. Many dental procedures require quite complex behaviors and actions from our patients, which need to be explained and learned. For children, this requires small, clear steps. This process is termed as behavior shaping. It consists of a defined series of steps towards ideal behavior. It is most easily achieved by selective reinforcement. Selective reinforcement is by appreciating only desired behavior and ignoring bad behavior. So what needs to be reinforced gets reinforced, and what needs to be ignored gets ignored. So the child progressively starts showing the desired behavior. That's called selective reinforcement. Reinforcement is a strengthening of a pattern of behavior, increasing the probability of that behavior being displayed again in the future. So when you say thank you or appreciate or smile every time they show good behavior, they tend to show the same behavior again and again. Anything that the child finds pleasant or gratifying can act as a positive reinforcer. Stickers or badges are often given at the end of a successful appointment. These are material reinforcers. Material reinforcers are substances given at the end of a successful appointment. However, the most powerful reinforcers are social stimuli. That's social reinforcers. Social reinforcers is such as facial expression, positive voice modulation, verbal praise, approval by hugging, etc. Negative reinforcement is a strengthening of a pattern of behavior by the removal of a stimulus which the individual perceives as unpleasant. A negative reinforcer, as soon as that is called the negative reinforcer, as soon as the required behavior is exhibited. The stimulus is applied to all actions except the required one, thus reinforcing it by the removal of a negative stimulus. This should not be confused with punishment, which is the application of an unpleasant stimulus to inappropriate behavior. That is, punishment is the removal of a parent from the operatory when the child shows bad behavior. That's parent separation. That's a punishment. Distraction. This approach aims to shift the patient's attention from the dental setting. I was talking about audio analgesia the other day, right? Before. So this approach aims to shift the patient's attention from the dental setting to some other situation or from potentially unpleasant procedure to some other action. So here the patient is distracted so that he or she does not concentrate on what is being done on them. Cartoons and audio tapes have been shown to reduce disruptive behaviors in children. You can use nowadays with artificial intelligence, you have 4D goggles and stuff like that to distract the child. Anything that distracts them from the procedure that's been done on them, like you pull the cheek of the child while you're giving a local anesthesia, while the alginate impression is inside the mouth, you ask the patient to lift their legs, something to distract them from the procedure that is being done in their mouth. Short-term distractors such as diverting the attention by pulling the lip as the local anesthetic is given, or having the patient raise their legs to stop them from gagging during radiography or impression making may also be useful. The dentist who talks while applying topical paste and administering local anesthetic is also using a distraction with words. Modeling. The technique is based on the psychological principle that people learn about their environment by observing others' behavior. Using a model, either live or by video, to exhibit appropriate behavior in the dental environment, you modify the uncooperative or anxious child's behavior. For best effects, models should be the same age as the target child and should exhibit appropriate behavior and should be praised after the good behavior or after the procedure being done successfully. Hypnosis or hypnodontics. Robertson in 1980 suggested that hypnosis or psychosomatic or suggestion therapy can be called hypnodontics when employed in dentistry. It is an altered state of consciousness characterized by heightened state of suggestibility. Greatest benefit is the reduction of anxiety and pain. The disadvantage is one should be trained to do hypnosis or hypnodontics, which is not taught in our curriculum. Coming to the physical behavior modification technique, the first one is called the aversive conditioning, where you use a hand over mouth technique. Dr. Evangeline Jordan in 1920s suggested this technique of hand over mouth technique, but the American Academy of Pediatric Dentistry has taken it out from the repertoire of behavior modification techniques, because this, after many studies, people feel that hand over mouth technique is not acceptable by parents and the child. So this is not being used in our clinical practice anymore. If a normal child will not listen but continue to cry and struggle, hold a folded napkin over the child's mouth and gently but firmly hold his mouth shut. His screams increase his condition of hysteria, but if the mouth is held closed, there is little sound and he soon begins to reason what the reason why Dr. Evangeline Jordan applied hand over mouth technique to modify the child's behavior. Hand over mouth exercise. Levitas in 1974 described hand over mouth technique as hand over mouth exercise on rope. A hand is placed over the child's mouth and behavioral expectations are calmly explained. You are not raising your voice, you are just holding the child's mouth closed so that he or she is able to hear you. His condition of hysteria is not increased. The child is told that the hand will be removed as soon as appropriate behavior begins. When the child responds, the hand is removed and appropriate behavior is reinforced by smiling at the child or saying thank you. This was described by Levitas in 1974. So before using home, you need to take an informed consent from the parent. Airway should not be restricted. It should be made sure that only the child's mouth is closed and not the nose. Do not use home in children due to age, disability, medication, or emotional immaturity is unable to cooperate. Physical restraints, which can be active and passive, are used to restrain the physical movements of the child so that it doesn't harm him or the personnel. Active and passive. Passive is again classified as for body, for extremities, for head, and to keep them out. Active is usually a person who can be the patient's parent or the dental assistant, restricting the child's arm or stabilizing the head. Physical restraints are used to reduce or eliminate untoward movements which can harm the patient as well as the personnel, like I said earlier, and to protect the patient and dental staff from injury. To facilitate the delivery of quality dental treatment also, it is used. Restraints for the body can be papoose board, triangular sheets, towel and tapes, beanbag, or a pedi wrap. A papoose board is a custom-made board which is available in different sizes for different size children. It straps the child up in the board. The picture is shown here. The child will not be able to move his hands or legs in a papoose board. But papoose board definitely needs some amount of cooperation from the child. He or she should be willingly lying inside the papoose board. Papoose board is a commercial wrapping for the body. It's simple to store and use. It's reusable, available in different sizes, has attached head stabilizers, and disadvantages of full body restraints is hypothermia. The child can get quite heated up inside the papoose board. A beanbag dental chair insert. You all must have seen a beanbag. So it can be, a beanbag can be inserted onto the dental chair. This was developed to accommodate, hypotonic and severely spastic patients who need more support and less restraining. It is reusable and one side fits most patients. So hypotonic patients benefit from the use of a beanbag. Or severely spastic patients, they need more support and less restraining. Remember that. Pedi wrap. Pedi wrap comes in different various sizes. It allows some movement. It requires additional straps to maintain body position. This is used usually. This sort of pedi wrap can be used on the elbow so that the child does not fold the hand or disrupt an injection procedure. Restraints for the extremities can be Velcro straps, pussy straps, or towel and tape, which can be used to tie up the rest extremities, which are the hands and legs. Restraints for the head positioner, forearm body support, which is active by a patient's bystander or your assistant, plastic or doggy ball to stabilize the head. For the mouth, you can use bite blocks, mouth prop, which can be the mouth prop, padded tongue blades, and finger guards, acrylic finger guards to protect the dentist fingers and keep the mouth open. A mouth probe allows accessibility to the opposite side of the mouth. It operates on a reverse scissor action. Okay, and you can use it on the contralateral side and work on the opposite side. Lip and palate lacerations or dislodgement of the teeth can happen if it is not used properly. So you have to be very cautious while using. You should not over open it acts on a reverses the action, over open the mouth drop and cause discomfort to the patient or damage to the patient's oral tissues. Thank you. You can mail me all your questions or doubts.